Hi, everyone. Good afternoon, and welcome to this session on Project Stellar. We are recording the session so that it's going to be available for everyone that cannot attend right now. So, as you know, we'll have introductions from Fatim and Osborne. We'll talk, and also Lyndon from High Impact Africa too. But as you know, Project Stellar was created to maximize impact of C19RM investments to strengthen labs. We'll hear about lessons learned, and teams are going to share their work they've been doing since the project started in 23 countries in Africa since 2022. The session is available in English, but we have simultaneous translations in French and Portuguese. So do we have the slide and the instructions so that people know how to switch to French and Portuguese as desired? We'll also have the recordings in the different languages. So with that, Lyndon, I'm going to pass on to you to start, if okay. Lyndon, we cannot hear you. Can you unmute?
You hear me now? Is it okay? Good afternoon.
Yes, thank you.
Excellent. As Marcella pointed out, we're very happy to be here today. We welcome this opportunity to further cement this collaboration with country stakeholders, including Uganda, who's presenting here today. Thank you, Uganda. And partners, including ASLM, CHAI, etc., on this Stellar project. As Marcella pointed out, the project was firstly conceptualized to really maximize our COVID-19 resources. And this project, particularly the Stellar project, has highlighted the importance and value of South-to-South collaboration, as well as technology transfer. The recent spate of outbreaks across the continent has further reinforced the value of the importance of surveillance. Today's presentation will highlight the excellent work being done to expand our footprint for surveillance, as well as proactively combat diseases. As the project, I must say, so far lived up to its name and nature, Stellar. It's been stellar. I will urge you to continue we'll urge you, the government is committed to continue to strive for greater impact, and also to document and share best practices. I'll be very brief because I wanted to hear more from the countries and the most from the presentation. But thank you, and as I said, the Global Fund remains committed to this project. This project is so far for us. Its name and nature, it's stellar by name, but also stellar by performance. So thank you. Over to you, Marcella.
Thanks, Lyndon. Osborne, would you like to say something before we go to our panelists, or Fatim?
Sure, thank you, Marcella. First is to appreciate the kind words from Lyndon, and also to appreciate our stellar Minister of Health country colleagues who have joined us in today's call to share these good words on some of the key achievements made by Stellar over the last 2.5 years. Our opening speech was meant to be made by Lyndon only. Fatim would be giving us the closing remarks. And with that, would want to welcome our keynote speakers. We have two of them in the house, Silva Mashata of ASLM, who will give overview of Project Stellar achievements in the 23 countries, then followed by a country presentation by Uganda Ministry of Health, Dr. Susan Nabada. We kindly encourage participants to raise or post any questions or comments you may have on the chat box. We will have a dedicated time for Q&A, but we do encourage you to post them at the earliest for ease of time management. With that, I want to welcome Silva Mashata to walk us through the overview presentation. Thank you.
Thank you so much, Osborne and colleagues, for this opportunity. And thank you, colleagues who have joined from wherever you are. We are super excited to share with you the overview and achievements for Project Stellar. So in the next couple of minutes, we'll give you the overview, and then like it has been highlighted, we'll hear from Uganda. So this presentation is being made on behalf of the technical assistance providers that is APHL, Clinton Health Access Initiative, and ASLM, who have been the partners providing TA in this project. If you could go to the next slide. And the project essentially has been implemented in a couple of countries, that is 23 African countries. And we focused on a couple of lab system areas that were mainly 5. That is, and then we have the water surveillance component, which was implemented by the APHL. So we would like to highlight that while we're implementing this project, it has been a multi-phased approach where we've been working with the ministries of health lab directorates to undertake deep dive analysis to find out the actual needs per country and then develop work plans and then do the implementation. So while areas of lab systems in terms of policy, testing, data systems, and lab-based surveillance were implemented across all the 23 countries, we need to highlight that depending on the need of the country, a particular scope would be provided to that country. And we'll be seeing that shortly in the next few slides. Next slide, please. And to allow us share some quick updates on especially the area of lab system strengthening in terms of policy and governance. When we started the project interacting with the ministries of health across the countries, one of the gaps that had been identified was to do with policies and governance. Some of the interventions were not being guided by current either guidelines or policies within the different countries. So different countries indicated their need at the time. And here we have a couple of policy elements that we supported the countries. When we started the project in 2022, we still were at the peak of COVID-19, and therefore a few months later, there was transition to integrating COVID-19 into routine healthcare services. So many countries did not have testing strategies, and therefore they requested for that support. So we developed national guidelines for integrating COVID-19 testing. There are countries that needed support to review their lab policies, other strategic plans, and they are well listed on the right-hand side of our table there. And some of the images of the documents that we have supported through this project to do for the countries to develop are highlighted in the images there. So we also need to highlight here that all this that we did was to address some of the scope work areas that the countries needed support for. And from these guidelines, we're able to implement. When we look at the next slide, where we do have an overview of some of the core areas where we had achievements across diverse work areas, we realized that after having the policies and governance, which we developed through coordinating with the ministries of health, developing those different documents, those policy guidance documents improved the governance that enabled us now to support the other areas that included improving access to testing. And some of the activities that were implemented included implementing of those guidelines, activation of some of the sites, because when we started, it was mainly testing for people who had symptoms, but now, based on WHO guidance, we were supposed to transition to routine healthcare services. They were supporting strengthening competencies of health service providers. There was the need to also support rollout of self-testing and then community testing and many other aspects of this to ensure that we increase access to testing. And throughout this process, we realized that up to the end, as we speak now, we had supported up to about 53% of the targeted health facilities, and then up to about 90% of the targeted health workers who have been trained to provide integrated testing. We need to highlight here that these are the targeted facilities that we as a project, we were targeting to reach and health workers, but while we are doing this, the countries have gone ahead to expand and extend the services to the rest of the facilities, rest of the health workers, and this work is ongoing. So it is beyond the numbers that we are actually representing here. In terms of surveillance, we have supported countries develop their essential guidelines for the surveillance components, trained in different areas of integrated surveillance, and a couple of countries have activated some sites for sentinel surveillance so that this can continue. And among the countries that preferred to have that scope of work. About the seven countries, about 57% of them have actually gone on to implement some of those activities. When we started the project, one of the gaps that had been identified was data management. Different countries had different siloed systems for collecting data. Either they had issues with data failing to reach the national level. In some cases, it was very difficult to aggregate this data. So countries indicated that they needed support to see how they can integrate. And indeed, we supported countries to integrate the different data systems that they do have. And we're excited to let you know that Uganda will be showcasing some of the work that is pertaining to, highlighting some of the work pertaining to data systems integration. And some of the sites that we did support, up 67% of those sites were activated to see that they have integrated systems. And then lastly, regarding lab systems, this one comprised of different areas, issues of specimen referral by safety, where we conducted the audits, lab equipment management. And one component that was key here that we learned through this process was supporting lab directors across the different countries during the Global Fund Cycle 7 application, providing the TA to see that we have the right priorities of the Ministries of Health addressed and incorporated into the application. And throughout these, different countries have received this support after 53%. In terms of the different facilities that have received support, we overshot this because need and support was moving on as we move along. So one of the things we need to highlight here is that some of the achievements, like you can see 53% or 40%, it's because while we're working along the way, some of the activities that initially had been prioritized were overtaken by events, and therefore they were not implemented because they were new upcoming priorities. Otherwise, overall, these are the general outputs that we do have strengthening across the different systems. And throughout this process, we learned some lessons. If we could go to the next slide. But before we cross to that, the other component that the project supported across the different countries, these were 6 countries: Ethiopia, Kenya, Mozambique, Tanzania, Uganda, and Zambia, was wastewater-based surveillance. And Uganda will be talking more about this. This was a pilot, and we found that several countries had at least 46 sites in each country testing per week over a period of almost about a year, and a wide range of a couple of samples were analyzed. And this was intended to see if we can use the environment, to see if we can be able to predict the upcoming outbreaks, such that timely interventions can be put in place to ensure that the Ministries of Health and the different countries actually are putting proper measures to prevent loss of life and morbidity. And also was largely under APHL that supported this scope of work. And some of the achievements, if we could go to the next slide, that came from this waste-based surveillance, is that it has been demonstrated through this pilot that waste-based surveillance can be good for monitoring pandemics, and therefore could be adopted for other pathogens. Some of the challenges we have experienced during this process is the complexities in terms of the communication, different channels. We have stakeholders engagement. It was delaying some of the processes we were undergoing, like reviewing all the work plans. And then the changing priorities was really very challenging because it depends on the needs that were available. One of the other issues was that relying on complementary funds, because some of our activities like procurement dependent on activities from funds from elsewhere. And we have learned a couple of lessons that we flashed here. And one of the key ones is that it's very key for us to amplify and strengthen the lab directorates to see that their priorities are actually incorporated into the resource mobilization processes. We also learned that effective coordination, issues of making sure that the technical assistance is provided in collaboration with the Ministries of Health is one of the effective ways of making sure that future planning and program implementation should adopt. And it allows flexibility and responsiveness of the Ministries of Health to address all this. So I'd like to end here, but this is the general overview across the different countries that we did support. And we would like to stop here such that we allow more time to hear from our experiences of Uganda. So Osborne, I would like to stop here and over to you. Thank you.
Thank you so much, Silva, for the overview presentations. As we welcome Dr. Susan Nabada of Uganda to walk us through some of the key achievements on data integration and wastewater surveillance. We do welcome participants to post any questions or comments you have on the chat box. Meanwhile, also kindly, you can introduce yourselves by typing in your name and country or a partner that you represent on the chat box. Thank you. Dr. Susan, over to you and welcome.
Thank you so much, Osborne. We are glad as Uganda to present the impact of Project Stellar's technical support to Uganda. And I mean, as Suva has clearly stated, our support was under data systems integration and wastewater-based surveillance. Next slide. So we want to thank the technical support that we received from CHAI and ASLM and APHL. And CHAI and ASLM supported us in 2 interventions. That was decentralization and integrating COVID-19 into routine healthcare service delivery, at the same time strengthening our data management systems. And the core areas in here was to make sure that we finally decentralize and integrate quality COVID-19 testing into our routine systems. At the same time, supporting the lab surveillance systems and the data management systems in an integrated manner. And as Silva stated, there was also support to the lab systems in terms of biosafety, biosecurity, the National Sample Transportation Network, and the human resource that needed to do this. And through this technical support, finally, the overall achievements that we had were accelerated transition of decentralized COVID-19 testing into our routine healthcare services. And we did this through development of guidelines. We trained health workers, and the health workers trained were beyond lab, the non-lab teams, the surveillance, the community health workers, and also the data management teams. And we also achieved integrating our disease outbreak data systems into one, and also managed to interoperate our lab information system with the electronic medical records in 5 of the facilities. Under the technical assistance via the wastewater-based surveillance, the main core areas was making sure that we were able to test COVID in wastewater and do next generation sequencing on the wastewater for SARS-CoV-2. And in here, we also added other pathogens of public health concern, but also to be able to use the data generated from these wastewater-based surveys to complement the case-based surveillance and monitor in-country trends. And the technical assistance we got as we speak, we're able to strengthen our lab capacity to implement the wastewater-based COVID-19 surveillance. And in this way, we are also expanding it beyond that, and also to support the use of the data that we are generating to complement case management and disease surveillance and monitoring. Next slide. In line with supporting the guidelines, we were able to come up with the COVID-19 test guidelines that were officially launched by our permanent secretary, and these guidelines are currently being used in the different health facilities. And that's our permanent secretaries officially launching the guidelines on top of the other guidelines we developed last year. Next. And under the data systems integration, we had one for the disease outbreaks, but also supporting the interoperability between the electronic medical records together with the lab information system. Why this? Because we had identified the gap, and we started by identifying these gaps because during the COVID peak, during the COVID pandemic, we had so many different multiple and siloed data management platforms that had different designs, technology, and data elements. Surveillance had its own data platforms. Laboratory, we had our own sample referral, case management, and stock and logistics management. They all had their own data management systems, and we all know there were some of them were using different application technologies like Android or web-based or SMS. And we all know the challenges that come with these siloed systems. The biggest one was data governance, the limited and untimely data access because you wouldn't know which system to get into to get the data that would inform decision making in such an outbreak. And above all was the high risk of the inaccurate data. So because of this gap, the support we got from Project Stellar through CHAI and ASLM, we managed to convene different stakeholders from the different software developers and systems users to integrate the different platforms through profiling the various data systems that were operating, determining the integratable data elements, mapping out the different user needs, lab, case management, surveillance, sample transport, and also profiling the different labs where these samples we are getting such that we are able to be linked to the National Sample Transportation Network. And in the workshops that we had, we finally designed an integrated database, integrated disease outbreak data reporting system that was linking the transportation of these samples from the surveillance to the transportation of these samples, finally to the different referral labs that we are testing for COVID. And so irrespective of whichever data tool that you are using, the lab information system for the different labs, the surveillance teams, the national sample transportation or the health facility, different systems that we are using, they would all finally connect into this integrated disease outbreak data reporting system, the results dispatch system, such that whatever system you are using finally would get the results through the results dispatch system. And as we speak, the result dispatch system that started with COVID, and you could access the results for COVID from the results dispatch system, can now be able to, we can now be able to have all the other outbreaks that are ongoing to be accessed through this results dispatch system, because the different testing labs are all linked into this. We initially piloted it into different 7 hospitals, but currently as we speak, we've scaled up to the other facilities. Next. That was for the outbreak data management system, but also with technical assistance from ASLM and CHAI were able to interoperate our lab information systems with the electronic medical records. The main gap that was there was mainly that the labs that had lab information system were not speaking to the electronic medical records. So the lab teams needed to manually enter the results back into the electronic medical records, which was prone to error and long turnaround time. But through the technical assistance, we identified some facilities that were already implementing lab information system and EMRs that had already been installed. We profiled and mapped the interoperable variables and interlinked the core function lab processes with the clinician patient care processes. And with this support, we managed to have the lab speak to the clinician, and interoperability was attained between the 2 systems, the lab information system and AMR. And now we can have only one entry point for the patient biodata, and the sample is taken through the system until when the clinician receives the result. At that time, we were piloting and operationalized 5 hospitals, but as we speak now, we've scaled it up to other hospitals. Next. The other technical assistance, as Silva talked about it, was the wastewater-based surveillance technical assistance to Uganda, and we thank Global Fund for this assistance because in 2018 on the African continent, Uganda recorded the most high number of outbreaks in 2018, Uganda alone. But also in the last 20 years, we've experienced over 30 VHF outbreaks in Ebola, Marburg, bacterial outbreaks like cholera, plague, anthrax, and viral outbreaks like influenza. And we are very vulnerable because of our location in the meningitis belt, because of the rapid urbanization, the globalization. All this makes us very susceptible. But we all know in outbreaks, the lab plays a very critical role in detecting and confirming and reporting these emerging and reemerging infectious diseases. Next. But it has always been that to be able to test you, you needed to have some clinical presentation. But we all know that clinical-based surveillance has a lot of limitations. It underrepresents the mild and asymptomatic cases. You all remember how we had a lot of asymptomatic cases in COVID that could spread the disease. We have also documented poor health-seeking behaviors as Uganda. So people won't come in when they are sick. And these limitations impact the accuracy of clinical epidemiological surveillance. So this needs to be supplemented by wastewater-based surveillance, and this is a very timely intervention because pathogens keep getting shed into feces of infected individuals, both for the symptomatic and asymptomatic. So wastewater-based surveillance has really gained traction in this because those that have very poor health-seeking behavior, asymptomatic, can be able to be caught early and can also help us detect the disease outbreak early. Next. So Project Stellar support in wastewater-based surveillance. We initiated it in 2023. We began by mapping out the different sites. As you see, Uganda, the purple dots you see, those are our different wastewater treatment plants. And that's the map of Uganda. And we have over 328, like 36 treatment plants and stabilization ponds. So we selected and sampled and piloted in 4 out of these sites. And these were mainly within the urban setting in Kampala. Next. So we designed the wastewater-based surveillance workflow with support from APHL because it was new, a new intervention we are beginning with. We are starting with, we constructed more swabs. We constructed the more swabs that we were submerging in the wastewater plants. And those are the pictures when we were submerging them. Then we would retrieve the more swab and finally take it to the lab for testing. And from the testing in the lab, the results will be uploaded in the system that we have just explained, the results dispatch system, and then the health facility, and the results will be accessed by the surveillance team, and so that decisions are taken. Next. So this is just a graphical presentation of the impact of the testing of the wastewater-based surveillance. In March to December, you can see the green is the concentration of COVID in the wastewater, and the dotted brown is the positivity rate for COVID. And if you notice that from around August to November, there was a high concentration of COVID in the wastewater. And later on in December, we had a peak of the positivity in COVID cases. So we in December, between August and November, we relayed this information to the Ministry of Health, the surveillance team, and the case management team, such that they used this information and the risk communication team, and they used this information to be able to mitigate the pending peak that was coming for COVID. And because of that, we noticed a sharp drop in the peak that came up because of the early interventions that were done. Next. And also, we managed to do wastewater-based surveillance next generation sequencing with support from APHL, and were able to detect some of the subvariants that were detected in the positive cases that we tested for COVID. Next. In wastewater. Next. So Project Stellar achievements under wastewater-based surveillance, as I've highlighted, from the concentration of COVID in the wastewater between August and November, we managed to relay the information to the surveillance team and intensified case detection because we're expecting a surge. And because of this, we noticed that the peak was short-lived. and as I've shown you in the previous graph. But also we managed to develop and validate COVID-19 wastewater-based tools and methodologies, and now we can use them to expand wastewater-based surveillance beyond COVID, just leveraging on the tools that we've developed. We also developed a wastewater-based lab information system that was integrated in the outbreak system that I've just shown you. And in the national COVID-19 testing guidelines, we managed to put in wastewater-based surveillance for COVID and other pathogens. And we've made some progress in the wastewater-based surveillance, next generation sequencing, and the lessons we are learning, we are going to use them for future wastewater-based surveillance, next generation sequencing. And from this what we have learned, we leveraged on this to be able to put the activities that are in the current GC7 to continue supporting the wastewater-based surveillance and be able to expand the scope of pathogens beyond COVID. And we have future prospects of making sure that we take this on through geological mapping, GIS integration, manual swab mapping, and developing an interactive online environment surveillance map such that we can be able to detect early any upcoming epidemic. Next. Yes, so that's the impact of the technical assistance given to us through SLM and CHAI and APHL from Global Fund, using the in-country funds, but through the technical assistance, and we managed to have the different achievements we had. We boast of an integrated disease laboratory information management system that we can access any outbreak wherever it is, wherever it's being tested. And also we are able to interoperate our systems from the lab and the electromedical records. And also we're going to continue using the wastewater-based surveillance intervention to widen the scope to be able to detect the epidemics early. Thank you so much. We want to thank the Ministry, Global Fund, National Water, who we worked with, Clinton, CHAI, APHL, and ASLM. Thank you so much, and back to you.
Thank you so much, Dr. Susan, for that very wonderful presentation showcasing some of the achievements by Uganda. You are always a trailblazer in some terms of some of the new initiatives in country, providing such a wonderful opportunity for other countries also to borrow and pick best lessons which can be implemented and lead to strengthening of laboratory systems across the region and other countries. With that, we'd want to go into a questions and answers session. Marcella, would you update us if you have any Q&A? I can see there's one question on the chat box. I can read it to the team to respond, and to other participants, please feel free to raise your hands so that you can be given a chance to raise any questions or comments that you have. So we can start with Janet. Janet, you had your hand up. Maybe you want to speak up? Janet, you want to speak up? So a first question to Dr. Susan and the Uganda team. We know currently Mpox is presenting a potential emerging threat with pockets of cases having been reported across the East African region. How is the country leveraging on the capacity built through Project Stella wastewater surveillance support to manage the response preparedness against Mpox, as well as other potential pathogens that may arise? Thank you.
Thank you so much for that question. From what I've just presented, that we've built the systems for wastewater-based surveillance, and in our current GC7, our plan was to widen the scope, and we had priority pathogens. Monkeypox was not yet on the list, but it's because it depends on the ongoing outbreak that you are responding to. And now, since monkeypox is one of the outbreaks we are responding to, it's something we've already thought about as we do our wastewater surveillance activities now. It's something we're going to put into consideration and prepare and get the reagents to be able to do this. I just want to thank Global Fund that has really released we got a release yesterday, 2 days ago, that we can be able to redirect and use some of the in-country funds to support monkeypox. And this is one of the things we are prioritizing to be able to do wastewater-based surveillance for monkeypox. Thank you so much.
Thank you so much, Dr. Susan, for the very elaborate response. We have about 20 minutes for Q&A. To all the participants, please feel free to either type your questions on the chat box. But for us to move quickly, we advise that you raise your hand so that you can be given the floor to raise any questions or comments you have. Marcella Zioda, do you see any hands raised? I'm not able to see the entire list from my side.
No, it's for nothing. We don't have it. We had Janet that we asked to unmute, but I don't know if Janet's still on the line.
There's a question from Shufang on the chat.
Oh, sure. Thank you. I can read it over. Many thanks for the very interesting presentations. I'm wondering if the presenters could share some insights on the availability of evidence on the efficiency gains through integrated testing. In addition, what are remaining challenges for some facilities that integrated testing has not become feasible? Dr. Susan and Silva, you want to weigh in on the question?
Yeah, thank you so much, Zhang, for that question. In line with evidence of efficiency gains, yes, the efficiency gains through integrated testing, because before you would have people who would come and test for COVID in a siloed manner when the epidemic was beginning. You needed to have people to test for COVID, to be able to collect samples for COVID, to be able to do data specifically for COVID. But now we are using the same people to be able to do all the other, as they do all the other work, they now do the COVID testing. And so in that way, we no longer need to have specific people that are supposed to be paid for to be able to do that. But also in line with integrated testing for on the different platforms, we've also seen efficiencies in that, because you can have one person who is testing all the different diseases, for example, TB, HIV, hepatitis, on the same platform. In this way, you are saving in line with the times that you need to have all these tests done independently using the same resources. But we've noted that integrating has not really become feasible in all the different testing facilities, because one, the human resource as you move lower is not yet, we don't have enough human resource to be able to do that. So they tend to prioritize what they would want, what they have to do depending on the load that they have. But also, since our integrated testing was getting lower to the communities and the like, we really needed to do further trainings into the people to be able to have them get on board, bringing other tests on board. So that was still a big challenge. But all in all, there's more efficiencies in integrating, because you save a lot on the human resource, on the finances that you're supposed to pay these different people, because you're using the same systems using almost one person. That's what I can say in that. Maybe Silva, you can add on.
Thank you, Dr. Susan. I think you put everything right. That's the efficiency that we see. For example, like Dr. Susan already elaborated, we are using the same specimen referral network. We are no longer not having COVID samples where, if needed for further testing, be transported separately. So that integration in terms of the other systems, like data systems, transport systems, the reporting, all these have been put in. That's really improving on efficiencies. But I think there was the last bit of the question in terms of what are some of the challenges that some of the facilities do face. Of course, one of the issues that we see here is that given that we are in a global community, many patients know that WHO has provided guidance in terms of the COVID not being a public threat. So the demand naturally has sort of gone down, and therefore there is a risk, potential risk, that in case a facility is stocked with supplies, they are likely to maybe to expire. But not only that, it's also, we've seen that COVID-19 itself has changed its epidemiology, the way it presents. So there could be missed opportunities, and that's why this integration and training would say that do not wait for people to present the symptoms, but treat those provided they meet certain criteria that are outlined in the guidelines. So the epidemiology so therefore, but overall, that's things.
Thank you so much, Silva. You are coming a bit on and off. There's also an addition in response to the question by Su Shufang from Namwaka. That explains that including optimized use of equipment, for example, GeneXperts, we now have an improved utilization of instruments with testing for TB, HIV viral load, EID, as well as HPV and other tests. So we'll go to the next question by Nafi. Congratulations to the team on data systems integration. Integrating systems comes with hesitancies from most countries regarding data security and sharing in many countries. What advice would you give to other lab directorates to navigate these discussions with the responsible ministries of information and technology that often carry the mandate on data security at the national level? Maybe Susan?
Yeah. Thank you so much. First of all, the lab directorates need to have visibility and be able to sit where these discussions are taking place. One, by first of all involving the leadership of their ministries, because the discussions between different MDAs is at the ministerial level. So by the time the Ministry of Health discusses with Ministry of Information and Technology, needs to have had a buy-in and from the lab directorates. That's the first thing to be done. But also having a governance structure for data management in the country. And for example, in Uganda, we do have that. It's via the Ministry of Information and Technology, but involves all the different MDAs, and the discussion takes place, and everyone all the different terms of reference for each ministry is clearly highlighted, and all issues of data security are all discussed in this meeting. So the second one is to have that governance structure between that is and for information sharing that is shared and led by the Ministry of Information and Technology. But beginning with the lab directorates, making sure that their ministers that represent them at that level are all in sync with what they are doing. And that's what we're doing as Uganda. And then we are able to air out our issues when we have a discussion with the Ministry of Information and Technology. That's what I can say about that.
Thank you so much, Dr. Susan. Any more questions or comments? Stella, do we have any hands raised? I can't see that from my
There
end.
is one more, Osborne. We're putting it up.
Oh, sure. There's one more question. I'll read it out from Uganda. Could we say that the project has brought an impact? Would it be beneficial for its continuity? Dr. Susan, over to
Yes,
you.
yes, it has. It has really brought an impact. We have an integrated system for for outbreak management. We've also noted the integration and what wastewater-based surveillance has brought to us, and we have used this to be able to have our activities and plans put in the GC7 basing on what we did. So it has really had an impact on in Uganda. And would it be beneficial for its continuity? As Silva explained, that TA comes in to support the countries to use their in-country funds. Yes, we've noted that it supports that, and where, especially in different particular areas and priorities where countries are having an issue, I think it would be something to continue with. But this comes with countries prioritizing, not in everything, but countries prioritizing where they really need that TA, so that they can have an impact of the different activities they've input. So I think that would be what I can say about it. But it shouldn't be that it should be for everything, but countries identifying priorities where they need the TA, so that the TA is given to utilize the in-country funds.
Thank you, Dr. Susan. And a follow-on question from Litsema again, based on the earlier part of the question you just addressed. Do we think it might be a challenge to implement in GC7 without use of Stellar TA?
As I've indicated, that countries, the way Stellar TA came in was countries identified areas where they needed TA. So if countries have done so in GC7, and that is what countries feel they need TA for, I think it should not be a challenge. TA should come where the country really needs the support from the TA provider. Otherwise, most countries are able to do some of the things, but where you really need a TA, I think it should be given. And we've noted the impact it has when you have TA for some of the activities, but not all the activities. So it will still be beneficial. And I know most countries have tried to ask for TA in the current GC7. But as the TA providers have identified and the challenges, the issue is usually with the in-country funds, because the TA comes, but it uses the in-country funds. So they highlighted those challenges, but if they are really mitigated, TA is still needed. We can't do without TA.
Thank you so much, Dr. Susan. Just chiming again that laboratory-based surveillance, inclusive of wastewater surveillance, remains an RSSH core priority, and countries were called upon based on their need and were at liberty to include requests for funding to support laboratory-based activities during GC7 grants. So your response is quite on point. A further question by Trevor. The wastewater surveillance has been an impressive area of work. To what extent can this approach be used to extend surveillance to other epidemic-prone pathogens on a routine basis? Dr. Susan, over to you.
Yes, thank you so much for that question. And actually, our follow-on from this project Stellar 1 was to expand the scope to be able to do surveillance for priority pathogens, because we noted the impact it has to do wastewater-based surveillance on COVID. So we put in a request for expansion of the scope, and we highlighted the different pathogens. And now monkeypox coming on board, it's something we want to think through with this reallocation that of savings that we have in GC7 to see if we can include that. So it's mainly around the priority pathogens that we'll be doing the surveillance in case we get the funds that we really need to have. Yeah. And it's the way to go to be able to predict the upcoming epidemics.
Thank you so much, Dr. Susan. And once again, reiterating the great efforts you have put preparing the slides, and your team, and the wonderful discussions and the responses. We are at 6 minutes to the end of the information session. And since there are no more questions on the chat box, I would want to welcome our colleague Fatim to give us the closing remarks. Fatim, please, over to you.
Thank you, Osborne. Can you hear me?
Yes, we can hear you loud and clear.
All right. Hello, good afternoon, everyone, again. And I would like to thank our TA providers, APHL, CHAI, and ASLM, but most importantly, also all the 23 countries that we worked with over the past few years to implement Stellar to support implementation of the COVID-19 response mechanism grants in all the countries. Thank you so much for your leadership, all the lab directorates, for your leadership and the extensive and exceptional work that has gone through implementing the activities and strengthening lab systems. So over the years, there has been several support to strengthen lab systems in the African region. And Project Stellar was just an add-on to this work. And here we have heard how we have utilized the funds, we have utilized the TA to further strengthen the lab systems. We've heard about how we are supporting integration, interoperability of systems, such that we improve service delivery, improve turnaround time, improve value for money. But most importantly, we have seen how the TA mechanism of Stellar worked. We really incorporated and embedded the TA within the countries. The TA providers were not fly outs, they were actually part of the lab directorate. And Dr. Susan can confirm how APHL actually embedded its TA support in the country, and they worked very closely to build the capacity of the lab. And with this, not just for wastewater-based surveillance, but for other aspects of lab systems, we have built capacity that we can now say we can sustain the gains of this support such that we, and we meaning us in these countries, can now actually support each other. We have started a new project where we are doing peer-to-peer learning, and we have seen the success so far of how we ourselves are actually providing the TA. So the last question was on, we still need the TA to continue? Yes, we need the TA, but we do have the capacity. Now, APHL, CHAI, ASLM has actually helped, and others have actually helped build these capacities in the region. So let us continue to collaborate with each other, work with each other, and to ensure that we sustain the gains, and also ensure we could use the funds for so much more, not just TA, to further strengthen our systems. So I want to really congratulate Dr. Susan and her team, but also all the countries and also all the implementing partners for this great support. We continue to support lab-based surveillance, especially now with the Mpox pandemic. We want to now see how we can use what we have invested in to really ensure we timely identify disease threats and also curb them from becoming pandemics. We going back again, putting on our boots, putting on our lab coats, going collecting these samples and seeing how we can really further curb disease threats in the region. And for me, this would be the real success of us implementing, especially wastewater-based surveillance in the region. So I know, like Susan said, and other countries as well are extending use of wastewater-based surveillance, not just, for Mpox now, but others are using it for cholera and Ebola, etc., TB, etc. So let us continue on this. We're here to support as needed. We have other forms of TA that are also available, and as needed by countries, we will look into it. Again, in closing, I want to also thank our communication team. I want to thank Osborne and the lab team, but also Lyndon and the High Impact Africa 2 team, but also all the other Global Fund colleagues that really supported Stella over the past few years, including the C19 Secretariat as well, and all our senior leaders here at the Global Fund. But also thank you again to everyone, and have a good evening. Thanks.
Thank you so much, Fatim. And that brings us to the end of the informational session. Thank you all and goodbye.